A very good day, my dear postgraduate students. The topic for the day is Barrett's esophagus, which I have pertinently taken from the recent advances. Only in a previous brevity, I had mentioned the importance of the recent advances. Topics like this appear seemingly simple, but look at the extent to which it has been analyzed by Safim Anjarwala and Neil Shepherd. The first person appears to be of Indian origin. Before we go deep into any topic, it is better to have a bird's eye view of the situation. And always pictures first. So we all know this is the esophagus and the stomach. This is the esophageal sphincter, which is preventing any reflux of the material into the gut tube. And this is the normal lining that you find in the esophageal tissue. There will be a muscular mucosa and there will be a lamina propria, submucosa, muscularis layer, and a serosa. This is what is being reflected over here. Now, this is a superb set of pictures which I might be showing repeatedly. I would like you people to kindly concentrate. So there is a normal esophagus and then there is a Barrett's one. There is a replacement by the glands. So in the epithelium, there are two types of metaplasia. One is the squamous metaplasia and second one is a glandular metaplasia, which is the Barrett's. Also, you find that there can be some pre-malignant changes, such as a dysplasia, etc., which can occur, a low-grade dysplasia, and then a high-grade dysplasia. Finally, there is a malignancy. This incidentally happens to be a Vienna method of typing the Barrett's esophagus. This will be again shown. And see what is happening over here. Whenever there is a reflux, you find normally I thought the squamous epithelium is more resistant. But in such kind of acidity, the glandular epithelium appears to play a better role. And probably it is the stomach that secretes the acid. And when those glands are again in the esophagus, they will be able to resist. So that is the meaning of this one. So you find that there is a replacement by the glandular type of epithelium compared to this. The risk factors are all given over here: male, Caucasian, increasing age, obesity, smoking, etc. Now, what is the definition? The columnar lined esophagus is defined as the replacement of the squamous epithelium with the metaplastic glandular mucosa. CLO. What is CLO? Columnar lined esophagus. There are many such abbreviations which you people should be familiar with. Now, where do you get this columnar epithelium? One, it can be from a cell of unknown origin. I do not know whether it is from the gastric origin or the intestinal origin, or it is such a cell within the esophageal wall itself. Or it can be a multipotent stem cell at the base. Please have these 2 points in mind. There is a stem cell and then there is a cell of unknown origin. Two things we shall be having in mind. Earlier, the squamous cell carcinoma was more common. In fact, esophagus means majority, 75 to 80% of the cases will be only squamous cell carcinoma. Now, there is a greater increase in the adenocarcinoma. Male, middle-aged, alcoholic, smoking, and overweight person infected with H. pylori are all prone for this adenocarcinoma or the Barrett's esophagus itself. So let us have these things in mind. As I told you the terms, these are very important and pertinent. 2 centimeter between the esophagogastric junction and the squamous epithelium. This is the area, 2 centimeter. And there should be at least 3 centimeters of columnar epithelium. There should be 3 centimeters of columnar epithelium. And when it is less than 3 centimeters, it is called as short segmented columnar lesion of the esophagus, SSCLO. Short segmented lesion of the esophagus. And sometimes you can have much shorter than this. It can be 2 centimeters or even less, which is called as ultra short segmented columnar lesion of the esophagus. That is why I said these terms we people should be familiar with. CLO, SSCLO, USSCLO. And finally, what are the neoplastic complications? This is an endoscopic picture of it. So there has been a reflux, there has been a damage to the lining, which is very obvious. A second thing, lower down, I think I can appreciate the rugosity of the stomach. One message is very clear from this picture. There has been an endoscopic investigation and an endoscopic prototype diagnosis. The author says that, in fact, the clinical and the endoscopic pictures shall suffice or be sufficient to make the diagnosis. The histological picture can reinforce or, in rare circumstances such as the ultra short segmented lesion, the histological picture can replace the endoscopic diagnosis. So please have this in mind. I am deliberately going slow because the topic, once it is finished, it should be ingrained into your mind. Again, a beautiful picture. Line diagrams like this always try to write or draw in your exams. So this is a normal epithelium, stratified squamous, from which I am getting a replacement. This can be because of the cells lower down which are getting differentiated into a glandular type of epithelium. There is a gland formation. And esophageal injury is there because of the Barrett's esophagus, and that itself can be because of the reflux. And if it persists, if the patient is having the other qualities, it can develop into a dysplastic lesion, a dysplastic Barrett's esophagus. And if ignored or if allowed to proceed, it can develop a esophageal adenocarcinoma. So beautiful. Very simple set of pictures downloaded, but then they have to be superimposed in such a way that it has got a meaning with our text. Now, what is the pathology and the diagnosis of the columnar lining of the esophagus? It is an endoscopic diagnosis. We had seen it in the previous picture. There can be a pathologic corroboration or correlation in 30% of the cases. Rarely, the pathology can be more diagnostic. And in cases of ultra short segmented columnar lining of the esophagus, pathology can be diagnostic. So remember these points. But the question is it part of a gastric disease, or is it an intestinal metaplasia or a cardiac metaplasia, or is it a glandular metaplasia arising from within the esophagus itself? Where does it arise from? So, courtesy Mayo Clinic, beautiful sets of pictures. I think they have done the greatest contribution to medical education. So, the pictures speak for itself. There is a bile mixed and there is a reflux. Obviously, the eroding capacity of this, all of us know when we have got a heartburn before the exam. There can be the various glands such as the cardiac or the fundic, intestinal. Usually it is incomplete. Now what is incomplete, what is complete, we will be seeing. There can be a complete metaplasia. A cardiac metaplasia, fundic metaplasia, intestinal metaplasia, which itself can be incomplete or complete. Now, long back, the mucin stains were done. As I will be showing you in the pictures and explaining, it can be the PAS, periodic acid shift, or the Alcian group, commonly done. Mucicarmine does not differentiate the different types of mucins. Muc1 and Muc6 are useful in the IHC part of it. Cytokeratin, it is debatable. And CK7 glands and CK20 of the surface epithelium can be useful in the diagnosis. They say that these are relatively more reliable than the plain histochemistry itself. Histochemistry means special stains. Immunohistochemistry means antigen antibody. Molecular is something different. Immunohistochemistry is implicated because the staining pattern, you find that there can be changes. Fixatives also bring about some changes and interference with the routine and the special states. Observer variation is possible, and it cannot be used for a simple intestinal type of metaplasia, in which case you find that immunology is mandatory for a diagnosis. So you find that any of this kind of metaplasia can be preceded by an intermediate or a transitional type of epithelium. So these terms we shall again be, and what is more important will be a multi-layered epithelium at the squamo-columnar junction. Multi-layered epithelium we will remove. Also, there is another condition called the hiatus hernia. Hiatus hernia is a sliding hernia along the opening. The stomach comes into the thoracic cage. So much so, when an endoscopy is done, we can get more of a gastric biopsy than a esophageal biopsy itself, and this can be mistaken for a Barrett's esophagus. Also, it should be known that both of them can coexist, and the mucosal endoscopy itself is difficult in such sections. Therefore, these are some limitations in making a diagnosis. And after all, what is endoscopy? It is a tiny fragment of tissue, hardly about 1 or 2 millimeters, with which you are going to make a very great diagnosis. Nature's Review of Gastroenterology, again superb. So let us see what is in this. I would like you people to kindly follow my classes. So this is the normal stratified squamous epithelium, in which I am finding that there is a replacement by the columnar epithelium. The columnar epithelium also, see, it is not uniform. There are some goblet cells, there are non-goblet cells also. So we can call it as a mixed type of an intestinal metaplasia. Also, I find that the glands can be developing within the lamina propria. So this is an intestinal metaplasia. Let us leave it at that. And there is also such things as piling up and the loss of polarity, etc. Also, within the glands, I find that there is some kind of a change. This can be a low-grade dysplasia. Dysplasia means there are abnormalities, but the basement membrane is intact. And here again, I find that there is a high-grade dysplasia. There is a lot of this piling up, basement membrane is intact, and the features of it I had again given up. You people also will be knowing it. There is also a variation in the glandular architecture, a cribriform pattern, and a folding of the lining epithelium, etc. Finally, you find that there can be an invasive carcinoma. There is a breach in the basement membrane, individual cells go into the lamina propria or even further, leading to an invasive adenocarcinoma. This is a beautiful picture. I think now you people can put everything together and understand better. This I would like you people to kindly memorize. There is no other book because I have simplified it in such a way that I have deleted at least 50% of the words. This is a pathological reporting strategy for CL. There is a category 1, 2, 3, 4. This is the reporting format, what is the pathology and the observation. So, in a case of diagnostic, one, there is a native esophagus with adjacent normal glands. Observation, nothing much. Now, in the second one, there is corroborative endoscopic one. In this case, it is diagnosed straight away. Here, there is intestinal metaplasia with a gastric mucosa with or without disorganized glands. So, it is probably an incomplete intestinal metaplasia. In the third one, I find that it is suggestive but not specific. And there is a gastric type of mucosa, no intestinal metaplasia. It could represent something like a gastroesophageal junction or a stomach or a hiatus hernia. Finally, there is no evidence of CL. There is a normal esophagus and glands. So in category 1, it is diagnostic of CLO because of the esophagus being replaced by the glands. So this is a British Society of Gastroenterology that has given this. Kindly memorize this particular table. So also this. This is again, it is highly summarized. A biopsy, it can be negative totally. So nothing to worry about. Or it can be indefinite. We are at the borderline usually. We find abnormalities, but it can be non-invasive and of a low grade. And it can be invasive with a low grade or invasive with a high grade. So remember these words alone. It is sufficient if you can mention these two methods. One is the British Society. The second one is BN. The mode of reporting a Barrett's esophagus or a biopsy. So it is a metaplasia. And this gentleman, Norman Rupert Barrett, in the year around 1957 or so, he has identified this Barrett's esophagus. And look at the picture over here. There is obviously a reflux which has been diagnosed. Norman Rupert Barrett. And look at the metaplasia over here. Supposing this is given to me, I won't say it is the esophagus itself. So I am finding more of this goblet cells. Not that it doesn't mimic the colon, there is something wrong with it. There is an admixture, majority of the colonic goblet cells, but then there are some columnar cells also. And it looks a little bit like a stomach. So it is a kind of mixture that I am finding. So look at the columnar cells in this region, and this empty looking goblet cells. Now, what is your observation in this case? Now, this is the normal esophagus, in which there can be a hyperplasia of the lining squamous cells. And this is the metaplasia. And in the metaplasia, I am able to find the lining epithelium is replaced by glandular epithelium. One. Secondly, there are some ducts which lead to the glands, or the glands leading to the ducts. After all, gland will have to empty its secretion. So there will be ducts. There is a surface, there is a duct, and then there is a gland. And they are all supported by a lamina propria. In this case, I am finding that there is an inflammatory infection. Secondly, it is not very bland. I am able to see some dark areas. There is some amount of pleomorphism, folding in, etc. So there can be a dysplasia in this case. So I'll have to find out whether there is a metaplasia and it is gastric or intestinal, or confirm whether it is a gastroesophageal reflux disease and what is the nature of the inflammation. This is extremely important because sometimes when they take a biopsy, we suspect it to be more of a stomach than the lower end of the esophagus, wherein If it is going to be the stomach, the diagnosis will be more of a gastritis with a dysplasia. This is another important element. So we had seen the metaplasia. But see, there has been a metaplasia, there has been a replacement with the glands. I'm able to see the goblet cells and the columnar cells. Fine. But why this? There is a normal appearing squamous epithelium. It is not normal. I'm able to find that there is some downward elongation. But then there is also a proliferation. We used to call it a basal cell proliferation. This is called a squamous overgrowth. There is an abnormal lesion which is being covered by the squamous epithelium. Multilayered squamous epithelium at the squamo-columnar junction. The squamous epithelium overlying the crypts. And they can be intermediate and transitional epithelium also. This looks almost like a transitional epithelium. And it is multi-layered epithelium. ME is multi-layered epithelium. Important. And there can be early change to goblet cell metaplasia. This I will be showing subsequently. And it need not depend on the intestinal metaplasia for the diagnosis. So this itself can make us suspect and diagnose. This again is a difficult area for us because I am finding squamous epithelium as well as the metaplastic glands. And look at this over here. If it is, I think, going to be an endocervix, I'll be very happy to demonstrate. So there is a columnar epithelium and then it is vacuolated, tall columnar cells, and in between I'm finding a squamous one. So squamous metaplasia is very clear. But then look at the squamous epithelium. This is a oesophagus and it is multi-layered. Count the number of nuclei. So multi-layered epithelium. And this also, it is not a normal squamous epithelium. We can call it as hyperplastic or multi-layered, and you will have to admix it with the columnar epithelium that you are seeing. So in this case, I am finding a squamous epithelial base and it is being overlined by the goblet cells. Both are being present. Why do you get both? We shall see. Incomplete intestinal metaplasia. So again, in this case, it is being replaced by the columnar cells without vacuolation, and there are well-pronounced goblet cells. The Barrett's mucosa with incomplete intestinal metaplasia. The epithelium is composed of goblet cells interspersed with intermediate mucus. Both in the surface and in the glandular epithelium, I'll be able to see it. It is just a H&E stain at this magnification. Now, the special stain, what we had seen. And one of my favorite topics was Mucinistochemistry in gastric lesions. My thesis those days. Here, I am able to find a squamous epithelium and there is an intervening columnar epithelium. Lower down, I am finding a mixed type of gland with goblet cells as well as the columnar epithelium. And when a special stain is being done, I find that this is Alcian blue. It takes up a blue color totally, and then there is the PAS. The Alcian blue is usually positive for the colonic type of mucosa, and the gastric type of epithelium or the small intestinal can be positive for the PAS. That is why we do a combination of the PAS and the Alcian blue. There is an Alcian blue. This is very obvious, a colonic type of metaplasia. But in this case, are you getting this kind of a blue color over here? There is an admixture. And in some of the glands, I'm finding a clear magenta color. So it is a case of a mixed intestinal metaplasia having the properties of small intestine and the large intestinal mucosa. The neutral mucin is usually found in the stomach. Genotype and phenotype. What does it mean? Genotype and phenotype. Concentrate on these pictures. So what I'm seeing over here, there is definitely a metaplasia. And this diagrammatic picture I would like you people to kindly draw. Whenever there is a crypt is a depression from the surface. A villus is an elevation from the surface. And As we go more towards the surface, the cells will become better differentiated. Better differentiated means they are like mature cells and there is no malignant transformation from it. Even in a case of ulcerative colitis, the malignant culprit is in the crypt. It is not in the surface. Anyway, there are two types of epithelium, fine. Lower down, this pink color, it is called the stem cell zone. So it has got a potential. That is why you are getting different types of epithelium. You are getting a gastric type of epithelium and then you are getting a small intestinal or a colonic type of epithelium because it has got the potential. And what is the difference between this genotype and phenotype? Genotype in an organism is supposed to be the genetic information, whereas the phenotype is supposed to be the physical trait of it. Look at this one. It is supposed to be a BB homozygous dominant. But what I'm seeing here is it is purple. When it is going to be heterozygous, then again it is dominant, there is purple. Whereas homozygous recessive, it turns white. So the external appearance that I'm seeing is the phenotype and the genotype is the nature of it, genetic nature of it. So the genetic nature of it is this, whereas this is the phenotype that I am seeing. Now, what are all the various changes you get? It is again a repetition. I am able to see the anatomic stomach over here. This is a normal gastric mucosa squamous epithelium. There can be areas of ulceration and inflammation. Then there is an attempt for regeneration. We all know whenever there is a wound healing, there will be the development of this basement membrane and there will be a cellular multiplication that is going to fill the defect. Now, in this, we had spoken about the stem cell and any of the precursor cell. It has got a potency to change from the squamous to the glandular epithelium. That is what happens in your cervical epithelium also. Whenever there is a chronic infection and inflammation, the glandular epithelium gets changed into more resistant squamous epithelium. You get a squamous metaplasia. Whereas in this particular case, it is replaced by the more resistant glandular epithelium. And I find that there can be the glands also. There can be the development into the columnar and the goblet cells. Beautiful set of diagrams. I would like you people to kindly follow this. And now, who am I? This is a colonic crypt. As I told you, these are the mature cells. There are the columnar cells and the goblet cells. And lower down, I find that there is a crypt. There can be a branching that can be seen. And these are probably the stem cells that is over there. And in a case of this Barrett's esophagus or in any form of dysplasia, there are certain characters which I shall be again repeating. One is branching. And what happens? There can be a gastric corpus within the gland. I find that there is a development of the gastric type of a gland. Or there can be a Barrett's type of a gland over here. So these are the different types of this epithelium which develop. I find that there can be multiple types of epithelium which are present over here. So there is a gastric corpus and there is a colonic crypt. And in a case of Barrett's esophagus, there can be a mixture of these which are being present. And who am I? This is supposed to be a movie. Whenever we get words like this, there will be a movie behind. This is again a beautiful picture and courtesy will be David Littman. So there is a squamous epithelium, there is a proliferation and it is a multi-layered epithelium. I think I am seeing some basal layer, some intermediate cells and then the mature squamous cells. And these are being lined by the tall columnar cells, almost mimicking the foveolar type of epithelium, but then there are also the goblet cells in. There is a crowding of the gland that can be seen and there is some kind of a mild variation in the outline. So this is what is being seen over here. In this case, it can be because of any of these points. I would like the people to kindly remember this. It can be because of the gastroduodenal reflex. It can be because of the inflammation. It can be because of any of the treatment, or it can be because of the clonal changes. Therefore, I find that different types of epithelium come into progress. There is a development. Accordingly, you can have a change in the lining epithelium. And therefore, this is also getting reflected when you do an IHC. So this is CDX2 positive and this is CDX2 negative. Now, my dear students, this is a little complex looking picture which we shall try to make easy. So this is the normal histology. There is a set of IHC over here and what is leading to the pathogenesis of the disease and what are the various types of changes we are expecting and how is it being diagrammatically reflected over here that we shall see. Look at this. So this is a gastric mucosa in which I can be having the foveolar epithelium, parietal cells and the chief cells. All of you know this. Again, the same set over here. In some, I find that there can be the foveolar cells which are more prominent, as in the case of cardia. And in the intestine, I find that there will be a mixture of the foveolar type of cells as well as the goblet cells in intestinal metaplace. Lower down, there can be the Paneth cells in any of the crypts. So what is happening over here is this. So in the fundic type of metaplasia, this is what will be seen. So there will be the foveolar cells as well as the parietal cells and the chief cells. So this is the type of metaplasia that you people get. And in a case of the Barrett's esophagus, it is the proliferation of the stem cells lower down, and these are the mature cells that we are finding higher up. So it is the stem cell which has got an immense potential to develop and differentiate, and sometimes it can even become a malignant lesion. And what we are seeing here is another one. The Barrett's esophagus itself can be because of inflammation. It can be because of the effects of the treatment. It can be because of gastroduodenal or the gastroesophageal reflux. And then there can be a clonal competition. So there can be varied amount of differentiation. Ultimately, you are getting different types of epithelium that develop. This I would like you people to kindly have in mind. And regarding the IHC, it can be either CDX3 negative, wherein there is a normal foveolar type of epithelium, or when it is going to be intestinal with the goblet cells, it can be CDX3 positive. Now, what is the pathology and the treatment in CLO? There are many modern trends in the treatment, and it can be based on the histological assessment and the response to the treatment. Surgical correction is needed, and they say that something called as fundoplication. These words are not very important to us because we are not clinicians, but then it will be better that we make use of it. Also, there can be acid suppressor. Just like a case of peptic ulcer, there can be acid suppression. There can be H2 receptor antagonist, again, which is being used in a case of peptic ulcer. Proton pump inhibitors, which are effective in gastroesophageal reflux disease. Anti-reflux surgery can be done, probably narrowing the sphincter or whatsoever. Then there can be a laser photodynamic therapy. PDT means it is a photodynamic therapy. Argon beam plasma coagulation. These are all some of the methods of treatment which we people can mention in the applied aspects. After all, you and I are going to diagnose a case of a Barrett's esophagus. And what is a clinician going to do? He can give an acid suppression, or it can be a proton pump inhibitor, or there can be anti-reflux surgery, or there can be a laser therapy, photodynamic therapy, argon beam plasma coagulation. These are all some of the methods of treatment which the author mentions. And what can be the pathological response to therapy? Whenever there is any form of treatment, you find there is a hyperplasia and there is a glandular metaplasia. There can be extensive necrosis whenever any treatment is given. There can be reactive changes. So there is a destruction and then there is a reformation. And whenever this occurs, it can mimic a dysplasia, and sometimes we can even overdiagnose a neoplasia, which is not there. Squamous reepithelialization can be there, and there are three patterns of it. One, adjoining to the squamous epithelium, it can proliferate. Two, as I mentioned earlier, at the glandular ducts. Third one, there can be a metaplasia of the Barrett's mucosal glands also. These things we should be having in mind. So whenever there is a treatment, when we give a biopsy, this is a problem. Many an endoscopic biopsy has been diagnosed as malignancy to be found benign later on. That is because there is a regeneration of the lining epithelium, or there can be slight dysplastic mimic, and that should be borne in mind. That is given in the picture over here. There is a columnar epithelium, there is a squamous epithelium, there is an ulcer. You find that there is a transitional type of epithelium, and there is also a residual embryonic cell which can develop into different directions. So that is why we are getting all these changes. This is a superb picture. In fact, it can be considered as the prototype thanks to John Hopkins pathology. So beautiful one. He has developed it. The R.A.T.S over here. The normal squamous epithelium, and then it is being replaced by the columnar epithelium with the goblet cells. It undergoes an undulation, and there is a development of the glands. The gland becomes elongated and irregular. Ultimately, there is an increase in the nuclear cytoplasmic ratio. There is a mitotic figure also. Everything has been shown over. I haven't seen such a good picture in my life. And what are the features? This is given in the article. It can be your age-old story of increased nuclear cytoplasmic ratio, loss of polarity, mitosis, atypical mitosis involving the full thickness almost in situ, large nucleoli, the contour of the glands, pleomorphism, contour of the nuclei also. Also in the architecture, there can be villi. Look at this one. It is being thrown into folds. There can be branching that can be seen. And there can be crowding of the crypts. Intraluminal papillary ridges. All these can indicate that there is a dysplasia or an impending carcinoma in a Barrett's esophagus. A wonderful picture. I would like you people to kindly draw it in your exam. And what are the causes for error in diagnosis? We had mentioned it earlier. There can be regenerative changes. There can be expansion of the proliferation, hyperproliferation, nuclear activity, villus and the papillary architecture. All this can lead to an overdiagnosis or an underdiagnosis. Also, because of the processing, there can be artifacts in a biopsy. Crush artifacts are very common. Tangential sectioning. We will be seeing that there are glands within the tissue. Therefore, we think that it is an invasion because of a tangential section. And there can also be staining variation, dark and light areas. So these are all some important causes for error in the diagnosis. So these things should be borne in mind. We have already mentioned it, the squamous reepithelialization, and it overlies the glandular epithelium, etc. What are the molecular markers? One will be the P53 overexpression, or it can be the Ki67, which is again a growth marker. A biological marker again can be antibody to alpha methyl acyl CoA. So these three markers we shall be mentioning. And this is from the review article. Those of you who want the details can go to this particular article. Again, another set of things. How do you make a diagnosis? Nowadays, you find endoscope is not just putting in a tube. They got all the, the aids for it. There can be a light. There can be a transnasal endoscope. There can be a video capsule which can capture the entire image and also take a biopsy of it. And sometimes it can even take a microscopy, probably because of the density of the gland or the blood vessel, it will be able to do. To some extent, the light penetration is being made use of by the endoscope, that they make a diagnosis which is nearly as correct as a microscopic diagnosis. And the non-endoscopic methods are these. So kindly mention these if time permits. Surveillance in a case of CLO. What do you people do? Patients are diagnosed and then they undergo a surveillance. Surveillance is nothing but a follow-up and then to find out in which direction it goes. This should be done with the consent of the patient and the risk factors should be analyzed. Long segments will have to be concentrated upon. Changes such as ulceration, dysplasia, etc. Look at this one. No dysplasia, you leave it alone or you increase the period between. When there is going to be a dysplasia, you will have to have intensive surveillance. Finally, when there is going to be a high-grade dysplasia, this has to be a regular wait and watch, rescope, biopsy has to be repeated, and if necessary, a surgery has to be done. This is called surveillance. What is surveillance? You are assessing, you are informing the patient, you are following up, having regular endoscopy, and if necessary, a biopsy can be done and a histological diagnosis made. The conclusions for this article shall be this. What is the role, what are the limitations, and the uses of the endoscopes, and what is the clinical endoscopic correlation? You find that there can be the number of biopsies that can be decided upon. Demonstrate the phenotype if required. Concentrate on the multi-layered epithelium. It can be overgrowing the glandular epithelium. What are the limitations of the biopsy? What is re-epithelialization? And still, in spite of all these developments, there is an alarming increase in the adenocarcinoma. We'll have to assess the response to treatment and decide the phenotype of it. All these segments I have mentioned earlier, and the problems in diagnosing the different types of metaplasia. And finally, there can be an inter-observer variation between the different endoscopists, different pathologists. Change is inevitable. Growth is optional. John Maxwell. Thank you for your patient listening.